Good evening.
Good evening.
Good evening, doctor. How are you?
I'm good.
All right. So, yeah, so your exam is nearing. It's on July, right?
Yes.
Is it online or are you?
No, I'm going.
Okay.
I'm
Where
going
is the center?
Istanbul.
All right. Okay. How is the preparation going on?
I'm trying my best.
All right. Okay. 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 So then shall we start in? Okay. I'll just give you a scenario. I'm sorry, I don't have the PowerPoint today. So the scenario is a 45-year-old lady. Am I audible?
Yes,
Yeah.
yes.
Okay. So for a 45-year-old lady who has come, who has been posted for laparoscopic cholecystectomy. The patient's weight is around 120 kg and the height is around 150 centimeter.
Okay.
And apparently she has no comorbidities and you are asked to assess the patient in the ward. She is posted for laparoscopic cholecystectomy for today. So you have you are asked to assess the patient in the ward. So can you take from there now?
Okay.
Thank you.
So for the assessment of the patient,
before that, can I just want to know some basic things? How do you classify this person according to the weight? Like,
so according to the weight, we calculate the body mass index of the patient, which is calculated by weight in kg divided by the height in meter square. So for this patient, it will be 120 divided by 150 meters square, which I guess could be more than 40 BMI.
Okay.
Okay.
And
so
how do you classify it?
Further, it is classified depending upon the BMI. Till 18 to 25 BMI is considered to be normal weight.
Okay.
About 25 to 30, between 25 to 30 is considered to be overweight. 30 to 34.9 is considered as obesity type grade 1.
Okay.
Then 35 to 39.9 would be considered obesity type 2.
Okay.
And above 40 would be considered morbid obesity.
Okay.
Type 3 or morbid obesity. And above 50 would be considered as super obese.
Yes. Okay.
And further, there is another way of classification is if the BMI is more than 40, it's called as morbidly obese, and they are higher risk for any procedure. If it is, if they are more than 35 BMI with accompanying comorbidities, still they would be considered as high risk for procedures.
Okay. So in this particular patient, so where do you place the patient in according to your class?
Consider as her as morbidly obese.
Okay. Okay. And now can you tell me the physiological, we'll just run through the physiology and then we will come back to your anesthetics management and everything. Can you tell me, according to the distribution of the, what effects can this obesity cause to each system? Let's say we start with the respiratory system of the patient.
So with the obesity, basically it is the increase in the caloric intake of the patient as compared to the expenditure. So in the respiratory system, it affects, it gets deposited into the airways and leading to right from the anatomical changes to the physiological changes. So it reduces the pharyngeal spaces because of the deposition of the fat. Eventually, the airway becomes more of elliptical size, shape, I mean, and the anterior posterior distances increase, but the lateral distances, the transfer distances are reduced.
Okay.
So they tend to go readily for an obstruction, and there is airway narrowing. So they are generally have puffy faces with more fat deposition in the cheeks, large tongues. So the upper airway is actually reduced in space. So going down, there is deposition of fat in the chest wall also. It reduces the lung compliances and the thoracic compliance also. So eventually it reduces most of the lung volumes especially the vital capacity, the FRC, and the residual volume. Expiratory reserve volume is reduced.
So
This
what
happens.
happens with the functional residual capacity? Can you compare that? Can you just stress on the functional residual capacity in this particular patient?
So in these patients, because the expiratory reserve volume is reduced, because of the abdominal contents, this is a position of fat, so it pushes the abdominal contents higher up, reducing the expiratory reserve volume and thus the functional residual capacity. The anterior posterior, the lung compliance is also reduced and the thoracic wall compliance is also reduced. So this eventually leads to greater degree of desaturation episodes.
Yes.
Because of the reduced FRC.
Yes. Okay. And is the reduction in the functional residual capacity dependent on the BMI of the patient?
Yes, as the BMI increases, the functional residual capacity drops down more.
Yes. Yeah.
So
Okay.
this happens even in standing position and more so in supine position. During anesthesia, because of the general anesthetic effects, the reduction would be further more.
Okay. Okay. And does the position have any interference with the lung capacities in this kind of patients while they are sitting up or while they are supine? And
so while they are supine, the functional residual capacity, all the capacities will reduce all the more. If you give them a propped up 30-degree position, the functional capacities are better. These patients are advised to lie in the lateral positions as it will reduce the airway obstruction in the lateral positions.
Okay. Okay. So when you say about the respiratory, I think it's better you emphasize on the positions as well, because that matters a lot to us anesthetists, because we will be, making the patient supine and everything. So just stress on that matter as well. I'm just saying in between. And any particular condition with respiratory, we should ask. In this patient, there will be anything else like
respiratory condition. We should ask whether the patient has any history of asthma or chronic obstructive lung disease.
Apart from that, because the patient is obese, any
history of obstructive sleep apnea?
Yes. Okay.
Should be asked for. And because that also has an impact on our anesthesia management.
And what does it do pathologically, the obstetric sleep apnea? Leaving behind the anesthetic part, what does it do pathologically?
In obstructive sleep apnea is defined as a cessation of the airflow for more than 10 seconds.
Okay.
Having such episodes at least 5 times a minute. This leads to complete cessation of the airflow, leading to desaturation episodes when they are asleep. So this can cause hypoxemia and hypercarbia.
Yes.
So
which can further long-standing can lead to what all things?
They can lead to insomnia. No, they can lead to hypercarbia.
Okay, it can cause more changes in the right heart and can cause
right-sided heart failure, pulmonary hypertension and right ventricular failures.
Okay, so we have to keep that also in mind.
So basically, pulmonary ventilation.
Exactly.
Ventilation perfusion mismatch and pulmonary shunts.
Exactly. So now coming to the
Can I add something, sir?
Yes, please.
Sir, it causes CNS desensitization to hypoxia.
Okay.
And centrally mediated apneic episodes. When it's long-standing.
Yes. Yeah. Thank you.
Thanks.
Okay. Now coming to the cardiovascular system.
So in these patients, there is increase in the cardiac output and there is increased oxygen requirement. So because of the body mass, because there is an increase in the body mass, there is an increase in cardiac output and the oxygen requirement of the patient. But at the same time, at times, initially to start with, there is a decrease in the SVR of the patient. So the cardiac output initially increases, but later on, these patients can experience higher, start developing hypertension and left ventricular hypertrophy and atherosclerosis. This is because of triglyceridemia also.
Okay.
So patient.
Yeah. Go ahead.
So patient can have left ventricular hypertrophy and can have cardiomyopathies also.
Okay. And regarding okay. And what about the hypertension and the pulmonary artery hypertension part?
There is hypertension. Atherosclerotic changes can also occur because of hypertriglyceridemia,
Okay.
and they can develop pulmonary hypertension
as well. And also there are chances for ischemic heart diseases. So we have to evaluate
coronary
that.
artery disease.
Yeah, and we have to also ask for the functional capacity in terms of how much they can walk and what is their cardiovascular functional status as well. And then there is another chance of what else? Pulmonary embolism also.
Pulmonary embolism and
there is a chance of deep vein thrombosis. That also I think you can mention while we are saying about the cardiovascular status. Okay, coming to the effects on the gastrointestinal.
In the gastrointestinal system, there is increased gastroesophageal reflux.
Okay.
Then there is delayed gastric emptying. There is a history. There is evidence of polylithiasis and
Evidence in the
fat deposition. Intra-abdominal fat deposition increases.
Okay. No, but anything else? So you said about
can have non-alcoholic fatty liver.
Yes. Okay.
And cholestasis.
Yeah. Okay.
And they can, if it is quite of a long-standing type, they may have cirrhotic changes also in the liver.
Okay. This initial steatohepatitis, is that reversible or irreversible?
That is reversible, but once they develop cirrhotic changes, that becomes irreversible.
And what about their insulin resistance?
There is increase in the insulin resistance, so they have a higher they have glucose intolerance. So the blood sugars they may develop diabetes also. Okay.
And what about gastroesophageal reflux?
There is a gastroesophageal reflux which develops. So these patients are prone to aspiration.
And also these kind of obese patients, there are chances of
gastric
hiatus hernia as well.
Yeah,
so we have to keep that also in mind. Yes. Okay. Now coming to the renal system, anything you want to add in any other systems, renal or CNS or
as CNS? CNS, because of the hypercarbia, there may be changes. Patient can have, as Dr. Narendra mentioned. Then renal, musculoskeletal system, because of the increased weight, there are during positioning of the patient, we have to be very careful about positioning. Padding of the bony prominence is very important. These patients can have pressure necrosis if they lie in some position for a longer time. So we have to take care of their position also.
There is any effect of fat distribution in the body with our
so the fat distribution generally happens in two types: the android type or the gynecoid type. So in the android type, there is truncal fat deposition. And these patients are more prone to cardiovascular diseases. In the gynecoid type, the fat distribution is more in the waist, the hips.
Okay. So waist hip ratio is a criteria we can check. Can
And in
you tell me
android,
the-
there is visceral deposition of fat.
Can you describe the weight hip ratio for females and male? What is the
If the weight hip ratio
more than 0.8 for females and more
for
than
females and 1 for males.
Yeah.
The hip measurement is more than 110. There is increased incidence of increased risk
of coronary artery disease
of
and
coronary artery disease. And if from females, if it is more than 88, there is an increased risk.
okay. So that's regarding the systems. Just I wanted to add about the obstructive sleep apnea part. You have to go little more. You have to explain about the obstructive sleep apnea part when they ask about that, because that is one thing they will stress on. So you have to describe what are the characteristic features of obstructive sleep apnea. So it is like the frequent episodes of apnea or hypopnea during sleep, where 5 or more per hour or more than 30 per night are often quoted as clinically significant. And apneic episode is defined as 10 seconds or more, as you said, of cessation of airflow. Then second characteristic feature is snoring. Third is daytime somnolence. Patient will be sleepy during daytimes, and the pathophysiological changes happening are hypoxemia leading to secondary polycythemia, which can be evident in the blood investigations. Then hypercapnia, systemic vasoconstriction, and that is what leads to the increase in SVR and hypertension, and also pulmonary artery hypertension due to pulmonary vasoconstriction. So when asked, what I meant to say is, obstetric sleep apnea is one part they can, in obesity, they can ask you in deep.
And there is one more, there is a drop of saturation by more than 4%.
Yeah. And then there is something like Dr. Narendra about the obesity hypoventilation syndrome, which affects the control of breathing, and it includes the obese patients who have a diurnal variation in ventilation. That is, PaCO2 will be very high. Carbon dioxide sensitivity and respiratory drive are partly under the control of the leptin. And relative leptin insensitivity in obesity is associated with a reduced ventilatory response to carbon dioxide. So what happens is that depressant drugs, including many anesthetic agents or analgesics, can accentuate this, and it can cause more hypoventilation syndrome. Okay, so this is why OSA is very significant for us. Okay, now coming to this patient, how would you go and assess, do a pre-anesthetic assessment for this patient?
So for this patient, I will ask for the history, history of the presenting symptoms, whether she has abdominal pain or any history of jaundice in the past. I would like to ask for any other comorbidities that are there regarding hypertension, diabetes. If she's diabetic, diabetes, or does she have any history of obstructive sleep apnea? Has she undergone any anesthetic evaluation before or any surgeries in the past? The course of anesthesia and the postoperative outcome of that surgery. Any history of acute infections and chest infections. And any other comorbidities, like I mentioned, hypertension, coronary artery disease, diabetes, hypertriglyceridemia.
Okay.
So if she has any history of any other surgery, I would like to know during that surgery, what was her weight, and did she experience the same symptoms that she is experiencing now if she has OSA?
Okay. And how do you do the assessment, like from system wise?
So system wise, for the respiratory.
So this is the history part you have said. Now you have to go for the system wise assessment as well. You have to.
Okay, so so
It's okay. Take it easy. Just think about it. And each system, how do you assess? Normally, how do you do it in the ward? Like,
Okay. So on examination of the respiratory system, I will look for the respiratory rate, whether there is increase in the respiratory rate, whether she has any foreign sounds or any wheezing during breathing. Then I would also look for the oxygen saturation on air, if possible.
yes.
Assess the patient in the supine position and
Okay.
also in the sitting position.
Mhm.
Ask for if she has any, she's better off in lying in the lateral position.
Mhm.
Then in the cardiovascular system, I would like to assess for her heart rate and look for any tachycardia, check the blood pressure. I would like to assess her cardiopulmonary status regarding her exercise tolerance on how much physical activities does she do? Does she have a sedentary lifestyle? Whether she can walk for good distances, take 2 flights of stairs. That will tell me about her cardiorespiratory reserve. Then
Can you say it with a classification or anything? Any accepted classifications about her exercise tolerance? Is there any classification which you know can grade the patients? It's okay. So
And-
just go through the classifications. If there is any, just you have to describe that as well. Okay. Yeah.
Then I would examine her airway.
Okay.
So I would look for her mouth opening, MPC classification,
Okay.
her dentition.
Mallampatti classification. Okay.
Yes,
Yeah.
particular classification, her dentition, whether she has any loose teeth, buck teeth,
Okay.
which can make our intubation very difficult. Whether the mouth opening is adequate, whether she has restricted neck movements or her neck movements are good. Then
Anything else on the neck?
on the neck.
We'll check the circumference of the
Neck
neck.
circumference can be checked for.
And what is the value? How much?
I
More
don't
than,
remember.
more than
but I think
17
around
centimeters.
40, 44.
More than 17 centimeters. Yeah. Yeah.
17 centimeters. Okay.
Yeah. Okay. Then
Then that is of the airway.
Yeah.
Then I would like to look for if she has a good IV access, because these patients can have difficult IV line accesses, and I would like to secure a good IV line access before we start the procedure. Whether there is feasibility of putting a manual blood pressure cuff on her arm to take the blood pressure. If not, then maybe I will have to go for an invasive line for
Okay.
her blood pressure monitoring.
What about the gastrointestinal part?
If she has any history of gastroesophageal reflux, then I would like to start with the prophylaxis for reflux.
Okay. What kind of prophylaxis are you planning?
So H2 receptors, antagonist, and protein pump inhibitors.
And if she says that she routinely complains of reflex, what precaution will we take for general anesthetics?
So we can go for a rapid sequence induction for this patient.
Okay. Now in the history part, again, because it's obesity, so the examiners will be thinking more towards the obstetric sleep apnea. So you have to check for a scoring for the obstetric sleep apnea. If you have heard of the stop bang. Yeah. So that is the mnemonic for S means snore, T for tired, O for observed you stop breathing during your sleep, P is for pressure, then bang, B is BMI more than 35, age more than 50, then N for neck circumference more than 16 inches. I'm sorry, 17 inches it was. And G is for gender. So there is a score where if the stop bank score high risk for obstructive sleep apnea, it will be 5 to 8. Intermediate risk will be 3 to 4, and low risk will be 0 to 4. So try to explain this also in detail. That will be very important. Okay. Now, investigations wise, what all will be looking at?
So for the investigations, I would like to do the routine basic investigations for her, like complete blood count. Then serum, the renal functions, like serum electrolyte, BUN, serum creatinine, then hepatic liver function test.
Okay.
Because she's posted for cholecystectomy. And I would also like to understand whether the obesity has affected her liver. Then her blood sugar levels.
Yes.
Fasting and postprandial levels.
Yeah.
I would like to do an ECG to
Yes.
see if she has any cardiac ECG changes. Considering her morbid obesity, I would also like to do a 2D echo for her to find out whether she has any left ventricular hypertrophy or pulmonary hypertension, which would be important
Will
for
you
us.
do an arterial blood gas for her?
Yes, in this patient, I would also like to do an arterial blood gas for her. Then X-ray chest for the routine investigations.
And what are the arrangements, special arrangements you will do in the operation theater?
So considering the obesity.
Before that, I'm sorry. How do you classify her as per the American Society of Anesthesiologists? In which category does she?
So she is morbid. She would be considered as morbidly obese. So she would be
In
categorized ASA 3.
Yeah. Okay. Okay. So what are the arrangements in the theater you will be?
So considering this obese patients, the important things for us is patient positioning, management of the airway.
Okay.
And
for that, do you want to add in an important thing? Anything?
Basically, equipment wise, the patient should be equipped to accommodate an obese patient, like the surgical.
So this is how, when you go in for the arrangements of the theater, first you have to think about the manpower. So you first you start with the manpower. So you say that because you are single anesthetist at that time, maybe you're on duty, you will always ask for another hand as help, because it's going to be a potentially difficult airway patient, morbidly obese. So always for another hand. So that you start from there, it is better. And then you can go by manpower, equipment, like that you can plan your answers. Yeah.
Considering this patient, I would like to have one more senior person or a helping hand for me to conduct this case. I would like to arrange for more manpower to get the patient on table and position the patient post anesthesia or pre-anesthesia as per the requirement of the theater. Whether the surgical table is would be able to take up the weight of the patient. Then adequate padding and accessories for positioning of the patient are available. For airway management, I would like to see whether I have some extra pillows or a ramp which will be made available for positioning for intubation. Then all the necessary things like difficult airway cart with video laryngoscope, fiber optic, small size tubes, adequate fitting mask, suction catheters would be kept ready. Airways, oral airways, nasal airways. I would like to keep them ready for the intubation purpose. And then I will confirm that I have all the necessary anesthesia drug armamentarium for my disposal. Then if I feel that the blood pressure monitoring would be a task, I would like to put an invasive line for this patient.
Okay.
So invasive monitoring should be kept ready. So these are the basic things I would prepare before taking the patient on table.
Okay. Yeah. And now coming to the anesthetizing part.
Okay. So these patients are prone for hypoxia and desaturation
Yes.
if they are suffering from OSA or otherwise also. They have a very limited FRC, so they can desaturate quite quickly. So thorough pre-oxygenation of the patient is very important in these patients. So before that, I would like to pay.
How do you define this thorough pre-oxygenation? Can you tell some, when you say thorough, you can say some time span or how many vital capacities you can, you can answer in that way, like 3 minutes of
100%
pre-oxygenation or 4 vital capacities, yeah.
Right. So I would like to pre-oxygenate this patient for at least 3 minutes with 100% oxygen.
Yes.
Till her saturation comes up to nearly 100%.
Yeah. Okay.
Before that, I would like to position this patient. If positioning of the patient is a difficulty, we would tell the patient to position himself comfortably
do
on
we
the
use anything to position the patient on the table?
There is a
pillow called Oxford pillow.
Oxford pillow.
Yeah. So
which can be
yes.
used.
So that actually props up the patient a bit so that the line, the jaw line and the chest will almost
at the same,
yeah,
in a straight line.
Yes.
So the position for airway would be a sniffing air position with a head high of reverse Trendelenburg of 30 degree would be the ideal position. We can give pillows below
you don't have to use the term reverse. You can use a propped up on Oxford pillow. Yeah.
Okay. So we can put pillows below the patient's back and give up a propped up position supporting the head well, or then we can put ramp position.
Yes, very good.
That we can position the patient with in that way. So the idea is this will straighten the view of the larynx and it will help us in laryngoscopy and intubation of the patient.
Okay.
So I would like to pre-oxygenate this patient for at least 3 minutes with 100% oxygen till the time patient saturation is around 100%. As considering the patient, I would like to use short-acting medications for this patient for induction of anesthesia purpose.
Why?
Because of the obesity, there is an increase of volume of distribution, and the lipid soluble drugs, there can be a delayed excretion and metabolism of these drugs. So we don't want the patient to be sedated.
Try avoiding the to tell about unless they ask about leading questions. You can just go on with your normal routine induction agents, because you might be putting in some lead questions. I think it's not necessary. When anyway they will come to you with the questions from pharmacokinetics and dynamics. So that's when. So I think you should go ahead with rather than avoiding the terms like short acting and all. Routine, what are the induction drugs you use? What are the analgesics you use?
I would like to pre-medicate this patient with glycopyrrolate and with midazolam, just to relieve the anxiety, but a very small dose to relieve the anxiety. I would like to use the induction agent as injection propofol for induction of anesthesia. Considering this as a difficult airway, once the ventilation patient goes under and I'm able to ventilate the patient, I would like to use succinylcholine for intubation of this patient. If the patient has a history of gastric reflux, I would like to do a rapid sequence induction on this patient.
Okay.
And then
when you do rapid sequence induction, how do you do that?
So after giving, once you start, before you start giving the induction agent, you first feel for the cricoid cartilage. And once the patient starts going under anesthesia, you have to press the cricoid cartilage on the, so that the esophagus gets obliterated. You maintain this cricoid pressure till the time you intubate the patient. In the meantime, you can give 100% oxygen. You can put on the 100% oxygen and just confirm whether you can ventilate the patient once.
Okay.
So that
Rather, I would suggest that when you answer about rapid sequence, when they ask how do you go in with anesthetizing the patient, you can say that I will do a rapid sequence induction. I will ask my assistant to keep his fingers on the cricoid so that start giving the pressure. I will explain to the patient that we will be pressing slightly, but you won't feel anything, because as you go into deep sleep, only we will put firm pressure. It's a gentle pressure we are going to put. Then I will ask who is going to give the drugs. I will ask them to give the drug. I will be holding the mask. I will not be ventilating. I will ask the patient to take in deep breaths. As the induction agent goes in and patient falls asleep, I will ask my assistant who is holding the cricoid to give more pressure. So how much pressure? How do you know how much is the 30 to 40 newtons is the pressure we give? Okay, so we ask them to give that pressure, and then you, as you said, you give the muscle relaxant of choice, either succinylcholine, or if Sugammadex is available. Now I think
you can use rocuronium.
You can give rocuronium. So if you are giving rocuronium or Sugammadex, what are the doses in such a patient?
For induction dose, we can use 0.9 to 1 milligram per kg of rocuronium.
Okay.
As a rapid sequence.
In the sense, actual body weight or lean, between lean body weight and actual body
weight? For
muscle
relaxants, you need to calculate the dose as per as the ideal body weight or the lean body weight. For non-depolarizing muscle relaxants. But for choline, succinylcholine, we have to give it as per the actual body weight.
Very good. Okay. And so what about the induction agents?
1 to 2 milligram per kg body weight, succinylcholine.
Okay. And what about the induction agent?
Induction agent should be given, propofol should be given as lean body weight.
Between lean body weight and actual body weight, we can give. Yeah.
And maintenance should be given as per the actual body weight. If we plan to give maintenance dose of propofol.
Okay. So now you are given the muscle relaxant now.
So after giving the muscle relaxant, I will do the laryngoscopy and secure the airway with the appropriate size endotracheal tube. Once the tube is passed under vision, the endotracheal cuff is inflated. Then I will connect the circuit and check for the ventilation. Once I confirm the ventilation, then only the cricoid, I will release the cricoid. I'll tell the assistant to release the cricoid pressure.
Okay, and if you are not able to intubate in the first chance, then what is your next step?
Then if I'm not able to intubate in the first attempt, then I will take another attempt to intubate the patient. If not, then I will.
Will you do anything different from the first attempt?
Release the cricoid.
You can use another kind of laryngoscope. Maybe you can try for video laryngoscope, or you can try for a
video laryngoscope.
Okay, after 2 attempts, then again, if it is failed,
then I would like to put a laryngeal mask airway and ventilate the patient.
Or else anything else?
Change of hands.
Remember the manpower thing. You have already a senior consultant. So immediately you have to bring him into this thing. So that you have to make sure that you answer like that, because they want to see how safe you are as an anesthetist. So, and you have to explain the whole difficult airway algorithm here if they go into that. So that is what they are going to ask. Either the DAS guidelines or any guidelines. You can, whichever you are confident in, you go with that guideline. So, and you can say that you use that guideline, but you should be thorough with that. Okay. Yeah. Okay. Now, in terms of analgesia and maintenance of anesthetics, what all will you do with these patients?
So for maintenance of anesthetics, I will use a short-acting non-depolarizing agent as a muscle relaxant. Maintenance can be done with volatile agents. I would prefer.
Short acting means what? What are you intending on? Like,
If I'm using rocuronium as the induction muscle relaxant while RI rapid sequence induction, I can continue with rocuronium.
okay.
If not, then I can use an intermediate acting muscle relaxant like either vecuronium or cisatracurium.
Okay. Yeah.
For maintenance,
What's the dose of cisatracurium?
it is 0.15 milligram per kg body weight.
Okay. Yeah. Okay. So how do you maintain the anesthetics?
We can use volatile anesthetics like sevoflurane or desflurane. Desflurane is preferable because it has a low blood gas coefficient. Because
Okay.
I can use desflurane for maintenance of anesthesia. If not, then we can use infusion of propofol for maintenance of anesthesia.
Sevoflurane?
Sevoflurane can also be used for maintenance because there is studies have showed that there is hardly any difference between the outcome of desflurane and sevoflurane.
Okay. And what about the analgesic part?
So for analgesic, I would like to use short-acting analgesics like fentanyl for maintenance of anesthesia. Fentanyl is analgesic, and NSAIDs like paracetamol or paracetamol for analgesia.
Will that be enough to cover the analgesic part?
I can use regional blocks. Like for this patient who's undergoing lap cholecystectomy, I can give tab blocks, subcostal blocks, and periportal blocks for analgesia.
Okay. What about morphine? What is your idea on using morphine in this kind of cases?
If morphine, we can use morphine, but it has to be given in a very titrated doses because it can cause sedation in the postoperative periods. So we do not want any kind of sedation for these patients in the postoperative period because they are suffering from obstructive sleep apnea, and they can have these episodes in the postoperative period.
And what about NSAIDs? Will you use NSAIDs for such patients?
Yes, we can use NSAIDs.
Okay. And any interventions for analgesia? Any kind of adjuvant blocks?
Tab blocks.
Yeah. And rectus sheath block.
Rectus sheath blocks.
When you talk about analgesia, you start by saying that you use a multimodal analgesia for patients, in which I can use paracetamol. Along with, I will use NSAIDs like diclofenac or ibuprofen. I can also add it with intervention like tab block or rectus sheath block, or else I can also ask the surgeon to do a local infiltrate the incision sites because it's a laparoscopic procedure. Okay. Yeah. So I'm just interfering because I'm just telling you, just add on like this, because what you're saying is the things, but just need to make it as a
refine it a little. Yeah. And I would like to maintain on oxygen and air combination throughout the surgery. Trying to maintain a normocapnia for the patient.
Yeah. And do not forget to tell about the calf compression stockings you use in such patients.
I would like to use DVT prophylaxis, mechanical prophylaxis for this patient.
Yeah.
So I would like to use compression
Stocking
stockings
or DVT pump.
DVT pump.
Yeah. So don't forget about it, especially in this kind of patient. Okay. And now what will be a plan for extubation?
Okay. So post-surgery plan for extubation would be I would switch off all the inhalational agents and monitor the patient's stop count to see whether patient has come out of the muscle relaxant and reverse the patient with neostigmine and glycopyrrolate. Once the patient starts breathing spontaneously, has adequate tidal volume, is back to consciousness, is awake, then only I would like to extubate this patient. And
yeah, you would like to extubate only if when the patient is fully awake. Yeah. And in the same position as you had intubated the patient. Okay. One more thing about analgesia, you can always add on by saying about central neuraxial blockade. If you are, if you have discussed with the patient and if the patient is willing, you can always say that before induction, you can try putting in a epidural catheter or even a central intrathecal opioid. If you think that can give, I can. There are long-acting opioids like diamorphine, which can be given intrathecally, which can last up to 16 hours at least. So you can talk about intrathecal opioids, just opioids, or epidural catheter, and in the post-op period as epidural infusions. You can talk about. There are also patient-controlled epidural analgesia, PCEA pumps. So you can talk about that as well. Okay. Now, post-op care, what all are your what all things, what arrangements will you be demanding in this kind of patients?
So after extubation, I would like to oxygenate this patient in the recovery. I will monitor this patient for saturation and ATCO2. And patient will be positioned in propped up position. And we will give oxygen by either by Hudson mask or maybe by nasal prongs if the patient is maintaining saturation quite well. So saturation of more than 95 would be acceptable for this patient. At the same time, I would be monitoring for his pulse, BP, blood pressure in the postoperative period, and whether the patient has any pain.
Analgesia part you have to definitely cater for, and so you can also talk about postoperative atelectasis. Avoid postoperative because already the
postoperatively, I would advise the patient to go in for physiotherapy.
Yeah,
and
spirometry, so that. Yeah.
So that she improves in the lung volumes and practice breathing exercises so that she can.
So you can, in the postoperative period, you can divide it into 5 aspects, and you can say, like, one is the respiratory management. You should avoid hypercapnia. You avoid atelectasis. So you do breathing exercise, incentive spirometry. You can also use CPAP machine if the patient has obstructive sleep apnea. So you can arrange for a CPAP machine, and you can also keep the patient where if there is a need for ventilation further, a crash cart and ventilator support. So you should keep the patient in an ICU, at least in a level 2 ICU, where all these facilities are there for at least immediate postoperative period. Then you can talk about analgesia. So that is the second aspect, analgesia. The third aspect, so analgesia, you can talk about PCA, you can talk about PCEA, sorry. You can talk about giving opioids, but as you told earlier about titrated doses of opioids, along with, again, multimodal analgesia, along with paracetamol and NSAIDs. And you can also talk about another one thing, because we had discussed lot about insulin resistance. So blood glucose
Blood
management
glucose
is
monitoring.
another important thing what we have to check in the postoperative period. And also blood pressure management, because these kind of patients are prone for high blood pressure. So we have to take care of the blood pressure management as well, if it is required. And most important thing is DVT prophylaxis. What kind of DVT prophylaxis can you give in this kind of patients? You can use low molecular weight heparin. You can continue with the mechanical prophylaxis as well. So you have to divide your post-operative care in 5 or 6. So when you number it and say it, they know that you know it like. So rather than if you answer it like that, the good thing is you will not miss things, or at least you will structure it. It is much better. You go it system wise, or if you go by, so it's all actually what you do, but just the way you present it, just be more arrange it and present it. That will be much better. Yeah. And I think, yeah, pretty much. Regarding the epidural and central neuraxial blockade, just you can describe. They might ask you a little bit deep into it. And yeah, one more thing, Dr. Dayaram has mentioned that is also very good, temperature management, because post-operative shivering and even hypothermia that can cause a lot of issues. So we have to take care of that as well. Yeah. And regarding the RAM position, they might ask you exactly to describe what exactly is a RAM position. So you have to give the ideal definition for RAM position. At what level exactly? What exactly is RAM position, and how do you measure? Because it should be that the suprasternal notch should be at the level of the tragus of the ear. So you just have to explain that as well. Yeah. Okay. I think it's almost 1 hour now. Yeah. So shall we? Do you want to continue with the next topic as well?
No, actually, I have not prepared for the next topic.
All right. Anyone else wants to go on with the pH and the carbon dioxide measurements? Anyway, it was nice, Doctor. You have done it good, but just as I said, it's very easy to say it from this side, but I know that.
I think is the question of practicing and speaking it.
Exactly. So exactly. So as you said, that's why it is good that you keep talking so that you will arrange your answers, and arranging that gives a lot of advantage, because they will see a very confident person speaking. So
I wanted to ask one thing is nowadays in many places it has been recommended that there is no need of humidified oxygen to be given to the patient. So is it correct to say that or not?
I'm not sure about it. I am absolutely
not. All these years I have always practiced humidified oxygen, but this
HME,
is
I still use that, and even
I have come across many such latest articles where they have said where they have tried to weigh the risk between humidified and dry oxygen as per the regards with infection is concerned. But I guess in the post-operative period, we are giving it for a very short time. So humidified oxygen should be a better choice as compared to dry gases.
Okay. I'm not aware of any studies. I am not in a position to. If there is anybody who wants to add into it, or anyone who wants to comment on it, I still use humidified oxygen, and I have seen in not only in India, where I worked in UK also, they use. As far as I know, we used. I don't know about. I think somebody else, if they want to add into it, I'm not sure. Sorry. Anyone wants to volunteer for the next topic, pH and carbon dioxide measurement? I think Dr. Deepak had said, but I think he had also there was a probability that he might not attend because he was stuck in some theaters. Anyone else want to try out the pH and carbon dioxide measurement?
Can we do it next time? Some other
No
session?
problem. No problem.
Can
I
we
can.
have a few more ICU sessions, ICU topics for discussion?
Sure. Do you want to suggest some topics I can prepare, or anyone, any other faculties, I can put it in the faculty this thing as well. So if you want to suggest some topics, we can do that, please.
So I would like some ICU topics which are commonly asked.
Yeah.
Like I actually don't know what kind of topics
So
are
one
asked.
ICU topic which I had already done a class here, but if you want, I can repeat that class again. That is sepsis. So that is quite frequently asked,
Okay.
because sepsis can take you to many other topics, like even into renal replacement therapy. It can take you to it can take you to ventilator management. Yeah, another one thing in obesity, they are going to ask you about the ventilator management part while you are giving anesthetics. You have to talk about which one do you prefer? Is it a volume controlled or
Pressure
a
control ventilation.
yeah. So how much?
Pressure control ventilation with PEEP.
Yes.
During spontaneous ventilation, I would like to give in pressure support to the patient.
No, with regard to the gastric insufflation in laparoscopy, so they will go deep into that. They can ask about the ventilator management when a patient is having laparoscopic surgery. So in a obese patient, so what is a strategy? So just read very thoroughly about it as well. So ICU topics generally, where they can ask about sepsis, they can ask about ventilatory management of patients who are in the ICU, then analgesic parts in analgesia in intensive care units. You can talk about the if you want any particular topics, please, if you suggest, we can go through it.
Okay.
And another thing which we haven't been talking about is I think pain management also they can nowadays, yeah. And ARDS is another one topic they can ask in intensive care. Yeah. Then cardiac output monitoring, what all cardiac output monitoring strategies are there. So all these things comes under the intensive care. So basically intensive care, they will be giving you a scenario. That's what I had to say, but I don't know if it has anything else has changed now. So they can talk about oxygen therapy in intensive care, and then the toxicity, oxygen toxicities, and all those things. Newer advanced things like in intensive care, like the renal replacement therapy or even ECMO. They can talk about extracorporeal membrane oxygenator, because that has come into more prominence, especially after the pandemic. So literally go through all those important things, but not very deep, like because there is not a EDAIC exam, so they will have only one station. So just go through the main things as an anesthetist, what all we need to know in the intensive care. So I think that will fetch you.
So can we have a session on sepsis and ARDS?
Yeah, definitely. Any comments regarding the topics from others as well, please?
AKI.
Yeah.
Renal failure. AKI.
Okay. Acute kidney injury and renal replacement therapy. Yeah. So sepsis, AKI, and ARDS. Yeah, definitely. We will.
Can they have a detailed discussion on anaphylaxis or?
Anaphylaxis, they can come. It may come as a as a case presentation, like maybe in the ICU, patient came in with anaphylaxis, was intubated in the emergency room, and further management and stuff. Yeah, definitely they can ask.
Nutrition in ICU.
Yes, very good. Yeah, that is another one topic now. You can go through the European Society for Parental and Enteral Nutrition (ESPEN) guidelines, and how much how about the nutrition things in the intensive care unit. What are the new which one do you prefer, the enteral or the parental one? All those things. Yeah. So that also we can, the nutrition in ICU.
In fluid management, perioperative and in ICU.
Fluid management, actually, it will be divided among the topics which are written. Like for sepsis, the fluid management, it comes along with it. AKI, the fluid management will be in it. ARDS also fluid. So fluid management, yeah, it may come as a whole topic, or it can come associated with each of the topics which we are discussing about.
I think only these many I can think of.
Anyway, I think Dr. Deepak won't be making it. So we will skip the part, but I would like to discuss that because these small topics like the pH and carbon dioxide monitoring will be might become a problem while we are doing, because in first station they can ask, or in the second station they can ask regarding this, the capnography, pulse oximeter, pH and carbon dioxide monitoring. So maybe next one topic I think I will do with pH and CO2 monitoring and capnography together, everything maybe. If you are interested, we can fix a date before your exam is on July 8th. Anybody else giving also in July? We can then do that in June sometime. Okay. Okay, thank you. Anything else? Should we? So shall we stop the session then?
Yes, sir. Thanks a lot.
Thank you, sir.
Thank you very much for
Thank you, sir.
attending, and thank you, doctor, for volunteering. It was nice. It was a very good session. All the best. Thank you.